Thank you very much, Dr. Benny. And thanks again, Matthew, for inviting me to this wonderful academic extravaganza. And I'm glad you gave me this topic. This is a topic very close to my heart because I sincerely believe that obesity has not been taken up by healthcare professionals the way it should. It has been left to mavericks and non-health professionals who are making a mockery of weight loss and doing all kinds of things. And the only way to combat this is for more healthcare professionals to enter the arena to combat non-academic or non-scientific methods of weight loss. So having said that, I'm going to share with you the experience, the way I have set up my obesity center many years ago. It's almost been 15 to 20 years now since I have my own. So I shall start sharing my screen. Yes. So this is, are my slides visible?
Yes, ma'am. Yes, ma'am.
Yeah. So this is my experience at doing it. I have taken a lot of help from, the internet when I was doing it at that time. And I've also used my own experiences, and we have evolved along the way. So I do not have any disclosures for this talk. So I want to talk first about the space, the team that is involved, the infrastructure and the protocol development, and how to lead by example. So this would be the overview of my talk. So basically, how do you organize the office in an obesity center? Is it the same as what you would do a regular OPD practice? Obviously not. The waiting area has to be such that the beginning, the therapy and the thought process begins right from the waiting area. So you must have posters. In my clinic, we have posters which have been designed by us in such a way as to positively impact the thinking and the knowledge of patients. So you have to, and this should echo the verbal advice that is being given by the healthcare professional. So the posters and what you are going to talk later on should be in sync with each other. You could have a nutrition corner at one area where you have a lot of material for the patient to browse through as he is waiting for you, and some good health focused magazines, because when the patient has come to you for weight loss, he already is motivated 90% of the time. Because he is motivated, he has come. And if you're going to feed him with such kind of stuff, it is going to have a better thing on the progress of what you're going to do. You place a brochure rack in the waiting area, give handouts, what you want your patient to know. So the process can start right from here. Otherwise, it is very time consuming. You can also include physical activity tips for all adults and their families. The other important practical thing is think of open arm chairs. You don't want to embarrass a patient who has come for obesity treatment by giving small little chairs which he can't fit into, and he already has body image issues, and you're not going to worsen that by having chairs which he can't fit into. So you have open arm chairs. I'm going to show you pictures like this. Now this is a picture from my obesity center where we don't have chairs at all. We just have benches. And that is why the patient is comfortable. He doesn't have to worry about fitting into a chair. And we have an open structure like this where the dietitians can sit. You can see the notice board with a lot of information. There are racks onto one side which you cannot see. So this is how you do it. So this is how the dietitian sits with the patient, talks. So the atmosphere has to be not that of a clinic. It has to be of a nice little center where the patient is comfortable, it is cozy, and he feels that he or she is welcome over there. So you have to have special examination accommodations. You must have appropriately sized gowns if you're going to do waist circumference, etc. And you must have a weighing scale that can handle higher weights, because these patients, again, as I said, they are already fragile minded. They should not feel more and more embarrassed because something is not fitting, or some gown is not fitting, or the BP cuff is not fitting. So the next thing is the team approach. Obviously, in obesity, the team approach is extremely important. One cannot do this alone. Your front office staff is the face of the clinic, and everybody in the clinic has to echo the same thing. There has to be some knowledge of obesity with everybody, even the front office. So they have a good rapport with the patient. So you must use these people to reinforce messages and goals. And you must have trained paramedical staff. They need not be, see, in places like ours, I'm in a tier 2 city like Belgaum, where you don't get qualified people. But if you can get simple graduates, I even have non-graduates who are very interested, whom you can train really very well. And these people can be trained to obtain the correct measurements, to calculate the BMI, ask questions about the lifestyle, physical activity, etc. You need to have a questionnaire which you can develop yourself. And some amount of counseling can begin right here, and all this information can be noted down by your other staff, the coordinators, so the doctor's time is saved and kept for counseling. So this is work that can be done by anybody. Then of course the backbone is the nutritionist, dietitian, who will conduct the dietary assessments and provide lifestyle counseling. And you must have a very strong dietitian. And on call, on your panel, you must have a psychologist, because a lot of these patients have several issues. You could be picking up depression, anxiety, you could be picking up eating disorders, body image issues, etc. And a psychologist has to be on board to sort out these issues. Otherwise, any amount of counseling or your diets are not going to work if psychiatric issues are not sorted out. Bariatric surgeon, yes, we cannot claim to treat each and every patient. If you have a person with a BMI of 45, obviously you may need the services of a bariatric surgeon. A social worker is required, because mind you, obesity treatment is not cheap. It is expensive. Whatever you use, it is expensive. We use, I'm freely admitting here that we use meal replacements, meal supplements. We may be using certain drugs for obesity, pharmacotherapy. Everything is expensive. So social worker is required to find out what is the status of that person, because you cannot prescribe things without knowing what is the social condition, the economic condition of the patient. Next is the protocol development. Each center should actually try and develop its own protocol. You can take the help of validated protocols, but I think it has to be individualized, because certain cultural norms, cultural mores in that area have to get into the protocol. You have to evaluate this. I need not tell this august audience the severity of the patient's obesity, obesity related risk status, and most importantly, what is the patient's motivation to lose weight and readiness to begin a program. Has he or she been brought in by a family member? Many times we have girls who are brought in by parents that she's going to get married, we're looking out for boys in the next 6 months, so please make her lose weight. That girl herself may not be motivated to do so. Or a husband brings in a wife and says that she needs to lose weight. So it is always evaluate the readiness of the patient to lose weight. Otherwise, your diet program is going to fail. So basically, there are three stages. Pre-contemplative. This is a stage at which the patient is not even thinking of weight loss. You will be surprised at the number of people who have a body mass index of 30, say age 50, and come to you and say, at my age, this is fine. I don't need to lose weight. So they are not even thinking of weight loss. So you cannot directly give them a diet chart. You need to bring them to the next level of stage of readiness of therapy, and that is a contemplative stage. So when they're in the pre-contemplative stage, you just need to talk to them about benefits of weight loss, what obesity can do to them, talk about the cancer risk, talk about the cardiac risk, diabetes risk, and then bring them to the next stage. And then finally you bring them to the following stage. So whatever stage the patient is at, recognize it and take him only to the next stage, not to the final stage of actually giving a diet. You must review all the comorbid conditions. That's the idea of doing an medically assisted weight loss. We are in the unique position of identifying and treating comorbid conditions alongside weight loss, and appropriately tweaking a diet plan based on the comorbid conditions, which non-healthcare professionals cannot do. And that is why I reiterate that we should be into this field, because we can also take care of the comorbid conditions. So everything has to be looked at, and this has to be incorporated into the protocol. When not to treat obesity, you must, when you have an obesity center or you're focused on obesity, first thing you should know is which are the cases that you should not touch. So if there is somebody who has active cancer, do not try weight loss in such a patient. Any very severe illness, do not try weight loss. Pregnancy is not a time to start weight loss therapies. You can of course limit weight gain, but no active weight loss. Eating disorders, these have to be first treated by a psychiatrist. Eating disorders, and then only you can attempt weight loss. Medical history, this is part of our protocol. Apart from everything else, you must take a weight history. So minimum weight as an adult, events associated with weight gain, recent attempts, previous modalities which were successful or unsuccessful. This is not what we are taught in medical school, but this is the weight history is very, very important. Weight loss to a level at or below the patient's minimum adult weight gain. So people have unrealistic ideas. I am at 80, I want to be 50. So has he ever been 50? That is something that you should ask. Ideal body weight may not be attainable when you are 50, 55 plus. So for goal setting, it is very important to take this weight history. Alcohol and substance abuse is something else that you must take care of. A history of eating disorders, I have already alluded to this. Take a drug history. The patient may be on drugs that promote weight gain or that may not promote weight gain. So you have to make a balance of this and use the right drugs and find out what is it that may hamper your weight loss attempt. So this history is very, very important. This is one of my most important slides. This is the individualization process. We talk about it as simple obesity, but simple obesity also has certain causes. And these causes broadly are into three important areas, whether it is slow metabolism for whatever reason, increased energy intake, find out the reason for it, reduced activity, find out the reason for it. For example, is the person into mindless eating? Just eats while watching TV or whatever, or slow metabolism. If a 65-year-old lady comes and tells you I want to lose 30 kgs, obviously the weight loss is going to be very slow. It's not going to be to that extent. Why is this important? This is supposing somebody has got severe physical limitations like osteoarthritis of the knees, and you ask that person to walk for 1 hour. That's not possible. And the individualization process comes here, and this is very important for realistic goal setting and patient education, so that they have realistic goals about their weight and weight loss. Then level of obesity is important, waist circumference is important, you need the proper equipment. The people have to be, your staff has to be properly taught how to take a waist circumference. I will not go into the details. This is just to show you what goes into actually managing an obesity center. So this has to be taught. You need a mirror in front of you like this, and how to hold the tape firmly. The correct equipment is important. And then you stage it. This is one of the best staging systems. It is not just BMI, it is also a functional staging, and that is going to decide. So you have a WHO classification here, and then you have a staging of obesity of who needs treatment and who does not. And this EOSS has now been incorporated into the ACE guidelines of this year. And you have to tell your patient to be patient. Weight loss is not going to happen in a hurry, and they have to be very patient for this. You must use technology. You can use text messaging, emails, SMS, because reinforcement is of utmost importance in these patients. They tend to forget. Lifestyle management is not easy, and there has to be reinforcement. Lastly, you have to lead by example. You have to be seen, you have to be actually known to be into fitness yourself. Habits of the staff should reflect a healthy environment. Even in your staff, encourage healthy snacks and lunches. And if you have vending machines, it should have only health food. And a personal commitment toward maintaining a healthy lifestyle is important. You can have something like walk with your doctor programs, walking club for your staff and patients. And as I said, lead by example. This is me cycling across somewhere abroad and having a cycling group, and you have to be seen to be doing these kind of things. You can put up your pictures. This motivates patients no end. If the doctor can do it, I can also do it. So thank you very much. I think I finished in time, hopefully, and I'm willing to take any questions at the end. Thank you very much.